Hi everybody, welcome back to Pulmonary. This is Chapter 5, which is Pulmonary Embolus, and what could be more classic than the pulmonary embolus? The good news is you already know a lot about this. This is a person who's got the sudden onset of shortness of breath, they've got clear lungs, and the form is that it generally speaking does not form in people who don't have risk factors. The risk factors for this are the things you know. They are people who are immobile, they've had surgery, they are people who have hypercoagulable states, people who have any form of cancer. All forms of cancer by definition can make you hypercoagulable. Trauma to lower extremities in particular, but basically immobile, traumatized people who've had surgery, and of course the thrombophilias. But immobility, surgery, and cancer are far more common than these thrombophilias. The thrombophilias are covered more fully in the hematologic section. The two simple answers is the most common is factor V Leiden mutation. The only one that makes the coags abnormal is the antiphospholipid syndrome, and the one most likely to need lifelong anticoagulation is the antiphospholipid syndrome. The diagnostic test, the best initial test is certainly a chest x-ray, and the most common x-ray is normal. Now here's the next question. Yes, the most common x-ray is normal, but when there is an abnormality, the most common abnormality is atelectasis. The most common abnormality is not Hampton's hump and wedge-shaped infarct or pleural-based infarct. That's not the most common abnormality. Now, yes, here it is. Here we okay, rear humping. I'm rarely humping. There it is. So that is found, but it's not as common as simple old-fashioned atelectasis. Now, the EKG, the most common EKG is sinus tachycardia. But when there is an abnormality, the most common abnormality to be found is nonspecific STT wave changes. When there is an abnormality in nonspecific STT wave changes, it is not right axis deviation and right bundle branch block, and certainly not the S1Q3T3. That is not the most common thing found on EKG. S1Q3T3 is found in about 10 or 20% of patients at most. It's an archaeologic remnant from the past when they used to go backwards from autopsies and say, okay, if you have 100 people at autopsies who actually died of a PE, what happened? Oh, look, those dead people had right bundle branch block. Yeah, but that's not what people present with mostly. They're presenting with sinus tach, nonspecific STT wave changes, and very unusually, signs of right heart strain. Now, the signs of right heart strain are important because you can do something different. What do you do differently based on that? And the signs of right heart strain, right axis deviation, is part of the indication for the use of thrombolytics, which replaces embolectomy. The blood gas will show hypoxia and respiratory alkalosis because you're breathing fast. Now, about 10% of people have a PE without marked hypoxia, about 10%, 10 to 15%. But remember that a person who's got a normal blood gas, a completely normal blood gas, has a negative predictive value of over 90%. Okay, they have an increased AA gradient and a respiratory alkalosis because you're simply breathing fast. Which one gets across easier? Oxygen or CO2? Oxygen or CO2? Which one gets across easier? CO2. So if you're breathing fast to get oxygen in, the CO2 gets out more than the oxygen gets in. The CO2 gets out more than the oxygen gets in. Yes, the S1Q3T3, there it is. Oh, yes, in one. And the Q and lead 3, the Q and lead 3, the S1Q3T3. Take a look and pause because I don't think it's as important. Next. Now, a patient with a recent hip fracture and develops a sudden onset of shortness of breath, and they got a pulse tachycardia. Remember, tachycardia is very common, so much so that if you have a normal pulse, it's profoundly unlikely to have a PE with a normal pulse. The chest is clear, the most common thing. The x-ray is normal, the most common thing. Sinus tach, but there's real respiratory alkalosis here. That CO2 is low. What's the next best step? And the next best step is it heparin, VQ scan, spiral CT, D-dimers, lower extremity Doppler, or an angiogram? Well, heparin is good, VQ scan is good, but you know what? VQ scans are pretty phony. We're not doing them too much anymore. The point about this question is this enough information to answer, say, to give heparin? And the answer is, it surely is. This is enough information to say to give heparin. This is a sudden onset of shortness of breath with clear lungs, a sudden onset of shortness of breath with clear lungs, and a normal x-ray, and this is enough information to say to give heparin. That's the point of the case. Spiral CT would be the most accurate test in this case because we don't need to do the angiogram. Angiogram is the ultimate most accurate test. However, pulmonary angiogram with a catheter has a mortality of about 0.5%, and 0.5% seems small unless it's your mortality. And if it's your mortality, you'll think it's quite a lot because you're the only one of you that you have. So if you die, you say it's a high mortality, and there's no reason to do it 99% of the time. D-dimers is what you get when there is a person with very low probability and you just want to test that if it's normal, it excludes. D-dimers, low probability, normal test, and it excludes a pulmonary embolus. D-dimer is like a SED rate. If it's normal, it helps exclude. If it's elevated, it doesn't mean very much. Lower extremity Dopplers is important because if you've got lower extremity Dopplers, it's positive, you don't need to do any other tests if your lower extremity Dopplers are positive because it doesn't change anything. That's why we call it thromboembolic disease, because if you got a thrombus in the legs, you don't need to do any other tests. It's enough. Now, the point of that question was, step 3 is very big on handing you the diagnosis and say, what do you want to do about it? Step 3 is very big on saying, here's a pulmonary embolus, sudden onset of shortness of breath, clear lungs, normal x-ray. What do you want to do? In that case, the point was that you have to choose between treatment with heparin and diagnostic tests. Is this enough information to answer treat? The answer is yes. Where should that patient be placed? Hospital ward, hospital ward. If they're hypotensive, in ICU with thrombolytics. Hypotensive, ICU with thrombolytics. Standard PE, hypoxic, hospital ward. The confirmatory test is spiral CT, standard of care now, standard of care, okay, especially if it's positive, extremely specific, extremely specific. The sensitivity of it may not be, well, it depends, but it's certainly more sensitive than the VQ scan. You might say, when should you get a VQ scan? The answer is pretty much almost never. Generally speaking, a VQ scan is the answer when somebody can't get contrast material. Some contraindication to the contrast material because the VQ scan nuclear isotope is less dangerous to kidneys, less dangerous to kidneys. There's a picture from my own hospital, actually. That's a beautiful picture of an embolus in there. It's a beautiful picture of an embolus being pointed out there. The dark is the clot. The dark is the clot. The white is the white stuff is the contrast. The white is the contrast, and the clot is displacing the white contrast. The clot displaces the white contrast. Now, VQ scan is, to be accurate, the x-ray has to be completely normal. If you have an abnormal x-ray, VQ scan is almost worthless if you have an abnormal x-ray. Now, the problem is that the VQ scan has a lot of suppositions. Oh, well, you have to have a normal x-ray or it's not worthwhile. Next, a positive scan has no clot, 15%. And a low probability scan does have a clot in 15%. Well, that's not too clear, is it? It's basically saying VQ scan is not the standard of care. Standard of care is spiral CT. So you might want to turn your mind off right now, some of you, and just say, okay, so chest x-ray, blood gas, EKG, and then spiral CT. That's it? Blood gas, x-ray, and EKG, and then I can go to spiral CT. Yes. Well, is the answer ever a VQ? Rarely. When? Can't use contrast. Can't use contrast. A completely normal scan is more negative predictive value than saying low probability. A completely normal spiral CT, however, is not as sensitive as a completely normal VQ, and that's a testable point. A completely normal spiral CT scan is not as sensitive as a completely normal VQ. You know what the problem is? Even in normal people, the VQ ain't too normal most of the time. This is just a picture of a ventilation perfusion scan. So by looking at this, you get the idea like, what's this black and white dot crap, man? I can't see anything here. It has to be a mismatch between ventilation and perfusion. Now, pulmonary embolus, lower extremity Doppler, if it's positive, it's excellent. You don't need to do any other tests. If that lower extremity Doppler is positive, you don't need to do anything else. We need heparin, and we need warfarin or dabigatran, warfarin or rivaroxaban, warfarin or rivaroxaban for 6 months. INR 2 to 3. If it's positive, you don't need any other tests. Now, about 30% at most, will originate in pelvic veins, so that means you can have a negative lower extremity Doppler, and you can easily have a pulmonary embolus with a negative lower extremity Doppler. The clot that may have been in the legs once has become a tourist. It's emigrated, got itself an F1 visa to your lungs. Now, the Doppler scan is normal even in the presence of a PE sometimes. Sometimes it's normal in the presence of PE, 30% of the time if it comes to pelvic veins. It basically means there's the lower extremity Doppler, and the word Doppler and duplex are going to be used interchangeably here. There's about 60 to 70% sensitivity. However, if you find the clot, you don't need to do any other tests. Ooh, the blue and the red, and the blue and the red, the blue and the red. The point about this is there's a color flow Doppler, and based on whether the blood is flowing towards you, away from you, about what the color is, and it's extremely sensitive if the clot's there. If the clot's there, it is. Problem is, not all the clots originate in the legs. D-dimer testing is very sensitive. A negative D-dimer means you don't have clot. A negative D-dimer has over 95% negative predictive value, but an elevated D-dimer doesn't mean much. A negative test, no clot. A positive test, nonspecific. You use D-dimer if you want a single test to exclude a pulmonary embolus in a low probability patient. A single test to exclude a pulmonary embolus in a low probability patient. Angiography is the answer to the question, which of the following is the single most accurate test? Is angiography. Which of the following is the most dangerous test? Angiography. What should you do last? Angiography. Do not swat a fly on your friend's head with an axe. Rarely used. But the answers to the question are the same. You see, it doesn't matter if you say rarely used. When is it the answer? We work backwards to the answers here. So you can say, we never do tympanocentesis for otitis media. Doesn't matter. It's the answer if it recurs. We never do a sinus biopsy for sinusitis. No. Recurs, persists, sinus biopsy. When is it the answer? Pelvic inflammatory disease. Oh, we don't do laparoscopy. Well, you do sometimes. When is it the answer? When it recurs, persists. Most accurate test for PID. Laparoscopy. A guy has a motor vehicle accident with a big hematoma, and now he becomes short of breath. Well, this is trauma. This is immobility. Of course he becomes short of breath, and sudden onset of shortness of breath with clear lungs is pulmonary embolus. Sudden onset of shortness of breath with a normal x-ray. Why'd you become so hypoxic if you have a normal x-ray? How'd you get so hypoxic if your lung fields are normal, huh? Now, if you're doing this section and it's in your area, if it's in your area and you're third-year medicine resident who sort of forgot to do step 3, I only meet them every day, or you're one of those unfortunate people that you have a program that says if you don't pass this by the end of your second year, you don't get a third-year contract. Plenty of places like that, and you're in a hot panic. Okay, if you're in the third year or second year of medicine residency, you'll think this is very easy because you have an experiential base. But if you're a pathologist, you won't have any experiential base. Gee, is this enough information to answer treatment? Yeah, it is. But try not giving heparin to people who have hematomas. Don't give heparin to people with hematomas. That's physician-assisted suicide, Dr. Kevorkian. This question is saying, what do you do when you've got to anticoagulate but you have a contraindication to anticoagulation? What are you going to do when you've got a hematoma, you got bleeding, you got melena, you got intracranial bleeding, and you want to heparinize, but you got a contraindication to heparin. You want to heparinize for the clot, but you got a contraindication. Filter. You want to, but you've got a contraindication. Surgical embolectomy is a disaster. It's only used in the most unstable patients failing thrombolytics. Embolectomy is very unstable patients failing thrombolytics. You should be doing thrombolytics first. It's for those who are failing thrombolytics. Now, IV heparin and low molecular weight heparin have equal efficacy. There's very few indications for IV heparin anymore, mostly when you need a short half-life because you're going to cut someone the next day. You're going to do surgery the next day. You're going to do angiography this afternoon. IV heparin has almost no therapeutic difference between this and low molecular weight heparin. One of the only ones is sometimes when people have valves, middle valves, but the main one is when you need a short half-life. IV heparin goes away in 2 or 3 hours. Now, pulmonary embolus, the treatment, heparin and oxygen, low molecular weight heparin and enoxaparin. Okay, the fondaparinux, the 10A inhibitor, fondaparinux is generally for prophylaxis. It's an alternative to heparin. So fondaparinux, first of all, it's a bit of an unfair question to ask you to choose between fondaparinux and low molecular weight heparin or heparin. And in general, it is not first. Heparin is first. Warfarin and rivaroxaban, or rivaroxaban for 6 months later on. And warfarin and rivaroxaban have equal efficacy. Warfarin is going to cease to exist, I think. First of all, the efficacy is not better for this in pulmonary embolus compared to rivaroxaban. And the other thing is you don't need to monitor INRs with rivaroxaban. You don't need to monitor INRs, and it's oral, and it's pretty cool, right? So dabigatran has the indication for AFib. Dabigatran is not a standard for PEs. Rivaroxaban is. Both of them get used for 6 months of therapy. Warfarin to an INR of 2 to 3. And what's the only time we go above the 2 or 3 of the warfarin? What's the only time we can go above the 2 to 3 of the warfarin? The only time is for mitral valves. Venous interruption filter is if you have a major contraindication to heparin, or you recur on heparin. Hey, you're heparinized. How come you got another clot? Because you need to filter. People who are contraindicated or who recur on anticoagulation. When are thrombolytics the answer? You're going into test day. When you want to know easier, work backwards from the answers. There's less of them. The other thing is, if anything I say seems to be different than what's in the book, which are you to pay attention to? The video. The video will always be more current. The video is being put out first because I want to be able to give you greater imaging. We can have many more images than we can get a book. The book would have to be 800 pages long with the number of images we're putting out in here. It would. We calculated. It'd have to be 800 pages. The second thing is that the book, the print cycle, just shipping books out, is slower than putting the videos out. So the videos are always primary. In other words, if something is different, the video is more current. Thrombolytics is for hemodynamically unstable people. That is not new. That is a 15-year-old endeavor. And for unstable for pulmonary embolus means hypotension, tachycardia, hypoxia, and replaces embolectomy. Thrombolytics are when there's hypotension, tachycardia, hypotension, hypoxia, tachycardia, hemodynamically unstable thrombolytics. That's the end for pulmonary embolus. Don't go into test day without knowing pulmonary emboli, and heparinize those people with clear lungs and the sudden onset of shortness of breath.